This video will discuss folic acid, presented by Medicos Online. Folic acid derives its name from folium, meaning the leaf of vegetables, where it is abundant. Chemically, it consists of a pteridine ring, GABA, and glutamic acid. It is photosensitive and naturally exists as polyglutamate, with 5 to 7 glutamates attached to the pteroyl group. Folacin is the name for compounds containing folic acid. It is absorbed in the jejunum in its monoglutamate form and transported to the liver, where the coenzyme tetrahydrofolate, or THFA, is formed. The formation involves 2 steps. First, 7,8-dihydrofolic acid is formed, and then 5,6,7,8-tetrahydrofolic acid is formed, catalyzed by NADPH-dependent folate reductase. THFA acts as the carrier of 1 carbon groups. These are organic molecules with only a single carbon atom. 1 carbon is attached to the 5th or 10th, or both the 5th and 10th nitrogen atoms of THFA. Folic acid has several general functions. It is beneficial in preventing cancer, with a reduced incidence of cervical cancer observed with supplementation. It also reduces homocysteine levels and helps prevent coronary artery disease. Deficiency of folic acid can lead to renal tubular defects. Causes for folate deficiency include increased requirements, such as during pregnancy. Defective absorption can result from sprue, celiac disease, gluten-induced enteropathy, resection of the jejunum, or gastroileostomy. Also, dietary polyglutamates must be cleaved by enzymes to monoglutamates for absorption. Certain drugs like hydantoin, dilantin, phenytoin, and phenobarbital can inhibit the enzymes that cleave polyglutamates, causing absorption issues. Other causes include hemolytic anemias and prolonged absence of vegetables in the diet, leading to deficiency symptoms like vomiting, abdominal pain, and diarrhea. Assay methods show normal serum FA levels at 20 nanograms per milliliter and 200 micrograms per packed cell milliliter. The histidine load test involves 15 grams of histidine with 24-hour urine collection. Normally, 35 milligrams of FIGLUE are excreted, but more is excreted in FA deficiency, which can be linked to peripheral blood pressure and macrocytic anemia. The recommended daily allowance, or RDA, is 200 micrograms per day, increasing to 400 micrograms per day for pregnancy and lactation. Deficiency manifests when DUMP is not converted to TMP, making TMP unavailable for DNA polymerase. This arrests cell division, affecting rapidly dividing cells like those in the bone marrow and intestinal cells. Macrocytic anemia is the most characteristic feature of folic acid deficiency, marked by a mature eosinophilic cytoplasm and an immature nucleus. It results in reduced production and increased hemolysis, leading to anemia, leukopenia, and thrombocytopenia. Folate antagonists include sulfonamides, which are analogs of PABA and are bactericidal. Trimethoprim and pyrimethamine, an antimalarial drug, inhibit folate reductase. Aminopterin and amethopterin are also powerful inhibitors of folate reductase. This diagram illustrates the structure of folic acid, composed of pteridine, PABA, and glutamic acid, forming pteroyl glutamic acid. This figure shows the 2-step production of tetrahydrofolic acid, or THFA, from folic acid, catalyzed by folate reductase. This image shows the structure of N5, N10-methanol THFA, a form of tetrahydrofolic acid. The next topic we will discuss is vitamin B12, also known as cobalamin, antipernicious anemia factor, or extrinsic factor of Castle, abbreviated as EF. Addison described pernicious anemia. William Murphy and George Minot demonstrated the effectiveness of liver therapy in treating this condition. Regarding the chemistry of vitamin B12, the structure includes a central cobalt atom, substituted pyrrole and imidazole rings. The variable group R can be cyanide, hydroxyl, adenosyl, or methyl groups. This image shows the detailed structure of cobalamin, or vitamin B12, where R can be a methyl, deoxyadenosyl, or hydroxy group. This structure includes a dimethylbenzimidazole nucleotide. Vitamin B12 is water-soluble, heat-stable, and red in color. It contains 4.35% cobalt by weight. The structure includes a corin ring, which is formed by 4 pyrrole rings coordinated with a cobalt atom. The corin ring has similarities to the porphyrin ring. The 5th valency of cobalt is covalently linked to a substituted benzimidazole ring. The 6th valency is linked to cyanide, hydroxyl, adenosyl, or methyl groups, forming a cobalamin ring. The different forms of B12 include cyanocobalamin and hydroxycobalamin. 8-O-B12 is the storage form. Methylcobalamin is the major form found in blood circulation. This diagram illustrates the structure and conversion of different forms of vitamin B12. Sources of vitamin B12 are primarily of animal origin, including liver, egg, meat, and fish. Curds are a vegetarian source. Lactobacillus can also synthesize it. The recommended daily allowance for vitamin B12 is 1 to 2 micrograms per day. Absorption requires intrinsic factor, produced by gastric parietal cells and occurs in the ileum. Intrinsic factor, a glycoprotein, binds 2 molecules of B12. This figure shows the absorption mechanism of B12, starting with its release from food and binding to intrinsic factor, or IF. The B12 and IF complex forms and is digested in the mucosal cells. B12 is then carried through transcobalamin 2 and stored in the liver as 8-O-B12 in combination with transcobalamin 1 or transcorin. Methylcobalamin is also a key form. This image shows the 2 major biochemical roles of vitamin B12 in the body. Deficiency can lead to abnormal homocysteine levels and neurological defects like demyelination. Subacute combined degeneration of the cord is a unique B12 manifestation, often mistaken for diabetic neuropathy or neuropsychiatric disorders. It affects lateral and posterior columns, causing sensory and motor disturbances. In the spinal cord, damage to the corticospinal tracts causes hyperactive tendon reflexes. Posterior column damage results in a loss of position and vibratory sensations. This combined motor and sensory impact is subacute combined degeneration of the cord, potentially due to defective SAM formation. This figure illustrates the relationship between vitamin B12, folate, and the production of methionine and succinyl-CoA. This image shows the structure and synthesis of S-adenosylmethionine, or SAM. From methionine and ATP, SAM is a crucial methyl donor in many metabolic pathways. B12 deficiency is common, especially in vegetarian populations in India, due to decreased absorption. Causes include gastrectomy, resection of ileum, blind loop syndrome, and malabsorption syndrome. Other causes of B12 deficiency include elderly people and Addisonian pernicious anemia, where antibodies attack the intrinsic factor. Iron deficiency anemia can also lead to B12 deficiency through gastric atrophy, reducing intrinsic factor production. B12 is assayed using radioimmunoassay, the Schilling test, the detection of methylmalonic acid in urine, and the FIGLU excretion test are also used. Peripheral blood and bone marrow morphology, along with the cilia gastrica, can also indicate B12 deficiency. Cystathionuria may also be seen. This slide displays a graphic representing vitamin B12 and its effects.